Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today we have another edition of Conversations with Cancer Experts. And today I have with me Dr. Dipenkumar Modi, who is from the Carmonas Cancer Institute, Hematology, Oncology, Bone Marrow Transplant program in Detroit, Michigan, a premier center in the Midwest. And we're going to talk about a hot topic, CAR T cells for second-line therapy. Welcome, Dipen.
Thank you very much, Dr. Vij.
So obviously, diffuse large B-cell lymphoma is a common lymphoma, and I understand that cure is what we're seeking in this kind of disease. Is that how you approach most patients?
Yeah, it is. I think, as you have pointed out, diffuse large B-cell lymphoma, it accounts for approximately 30 to 35% of all B-cell non-Hodgkin lymphoma. It is also one of the most aggressive types of lymphomas, and the goal of treatment, regardless of the stage, even if it's stage 1 through stage 4, is to cure. And usually we do rely heavily on chemotherapy or chemoimmunotherapy for this type of diseases.
The
In
first,
general,
go ahead, go ahead.
in general, I think as you will point out in the next slide, whenever we treat diffuse large B-cell lymphoma, we heavily rely on R-CHOP, backbone of chemoimmunotherapy. With the R-CHOP chemoimmunotherapy, we are able to cure approximately 70% of all diffuse large B-cell lymphoma, primarily in advanced stage, at stage 3 and 4. Now, lately, DLBCL was the standard of care for almost 2.5 decades or so. And lately, there was one phase 3 double-blind randomized controlled trial was done, which we call it as POLARIX trial, which essentially randomized patients with high IPI score of 225 into either R-CHOP versus R-CHP plus polatuzumab vedotin. And both groups received 6 cycles of chemotherapy and followed by rituximab maintenance therapy for 2 cycles. And that was the first trial which showed a superiority of R-CHOP, R-CHP plus polatuzumab vedotin over R-CHOP. The combination improved progression-free survival at 2 years by approximately 6.5 percentages. Essentially, the addition of polatuzumab vedotin, it reduced the rate of recurrence or death by 27%. So that's how I treat for newly diagnosed DLBCL. If they are high IPI or non-GCB subtype or double expressor subtype, then I try to prioritize addition of polatuzumab vedotin to R-CHP combination. But if they are localized or if they are low-risk DLBCLs, low IPI scores or GCBs, then I tend to use R-CHOP in those group of patients.
Yeah, you kind of preempted me with that. Was exactly my question was going to be like, how do you treat it frontline? So having got that perspective behind us, now we're going to focus on the main topic at hand, and which is how do you treat patients when they relapse? So what goes through your mind, and how do you approach these patients?
So I think the relapsed DLBCL group of patients are very, very tricky one. And now with the innovation and approval of CAR T cell therapy, it has gotten somewhat complicated. But as you can see here, I broadly divide my relapsed DLBCL based on the timing of relapse. We divide patients into 2 groups of patients. The one group is primary refractory, which means patients who never achieve complete remission to frontline chemoimmunotherapy, and patients who relapse within 12 months of finishing chemoimmunotherapy. So those are called high-risk group of patients. And the later part, second group of patients are late relapses, which means patients who relapse beyond 12 months of finishing frontline chemoimmunotherapies. In general, majority of the relapses, roughly 2/3 of relapses, they occur within the first 12 months, or they are the primary refractory disease, whereas late relapses, those group of patients account for roughly 1/3 or 25% of patients. And depending on their timing of relapses, that's how I decide my treatment. Now, if patients are primary refractory or early relapse within 12 months, then I tend to prioritize CAR T cell therapy, because clearly there are 2 landmark studies, phase 3 studies, which are ZUMA-1 and Transform trials. They have assured a superiority of CAR T cell therapy over standard of care autologous transplant in this high risk group of patients. So that's how I prioritize or prefer CAR T cell therapy in those high risk group of patients. Now we'll kind of review in the next few slides, but Yescarta, which is a Exicel and Lysocell CAR T cell therapy, are approved in this group of settings. Now, patients who are late relapses, now, those are typically considered chemosensitive patients, and we heavily rely on the salvage chemotherapy followed by autologous stem cell transplant. Now, in general, whenever we offer salvage chemotherapy, the CR rate are approximately 50%, 50 to 60% or so. And there are some caveats too. But those patients who have chemosensitive disease, CR or partial remission, we then move forward with autologous stem cell transplantation. And in general, if patients are in CR, the chances of cure on a long-term basis are around 50 to 55%. If patients are PR, those rates are a little lower, around 40 to 45%. And that's how we are able to, we deliver this group, this treatment. But in general, as you are seeing in this slide, as we break down on all CAR T cells outcomes, now, assuming that 70% of relapses occur in the first year or primary refractory, we are able to cure 40% of patients. So 70% of those 40% are 20%. So eventually we are able to cure 20% of all patients in the second line with the CAR T cell therapy. Now, moving on to the other group of patients, delayed relapses, late relapses, then assuming that patients from salvage chemo, they achieve CR, half of the patients, and those half of the patients, we are able to cure half of them. So eventually we are able to cure 5% of all DLBCL through autologous stem cell transplant in the second line setting. So that's how we break down. Now, there are also some group of patients, like patients who are elderly or patients who have many comorbid conditions who may not be candidates for these intense regimens. Then there are other non-curative therapeutic options available. As the slide is clearly showing here, they include polatuzumab vedotin plus bendamustine rituximab if patients haven't received in the past, or now we have bispecific engager antibodies, mainly epcoritamab and glofitamab, that can be utilized in the third line settings. Another one is loncastuximab tesirine, which is a CD19 antibody drug conjugate, which is approved in third line settings. Selinexor, as well as tafasitamab and lenalidomide. These are the other two options approved as well. So there are other avenues to therapeutic options to which you can utilize, but all the other options, they purely remain non-curative, and the goal is to achieve remission and improve their survival.
So restricting ourselves now to the CAR T eligible population, what can you tell us about the options available?
So for the audience, the CAR T cell therapy is a type of autologous cellular therapy in which patients' own T cells are engineered in a way that they target and they destroy lymphoma cells. These CAR T cells, they target B cell antigen or B antigen, which is a CD19 antigen, most commonly present in B cell malignancies. There are 3 CAR T cells approved for diffuse large B-cell lymphoma. Exicel, which is a Yescarta, which is approved. Tisacel, which we call it as Kymriah, that's approved. And the last one is Lysocell, which is the Breyanzi. Those 3 CAR T cells are approved. Now, broadly, if you can see here, the structure of CAR T cells are, the top portion is antigen binding site, which is almost the same, FMC63. That antigen binding site, it essentially binds to the CD19 antigen on B cells, which are the lymphoma cells. And then comes the transmembranous domain, or we call it as co-stimulatory domain. In Exicel, CD28 is a co-stimulatory domain versus 4-1BB present in Tisacel and Lysocell. The difference is CD20, this co-stimulatory domain, it mainly helps increase the T cell activation and persistence of those T cells in the body, and indirectly it helps with the anti-lymphoma activity. And the third one is CD3 signaling domain, which essentially activates which essentially provides a signal for T cell activation, and indirectly it causes a cascade of activation of those T cells and cytotoxic activities. So the only difference between these three CAR T cells are co-stimulatory domain, which is a CD28 for XC cell versus 41BB for T cell and lysocell. Those are the primarily difference that I can think of. There are also viral vectors which are different. Lysocell lysocell and T cell, they use a different viral vector compared to XC cell for their production.
So of this, I guess Axicell and Lisocell are approved for second-line use. So can you now review with us the data that led to this approval? We'll start with the ZUMA-7 that you mentioned before, which is on Axicell or Yescarta.
Yes, so essentially a couple of years ago, these now three landmark studies were done. The first of one is ZUMA-7. Essentially, older patients older than 18 years of age, those with good performance status, and importantly, patients with early relapse DLBCL or large cell lymphoma within first 12 months of finishing frontline therapy, or those with primary refractory large cell lymphoma were included. Patients were randomized to XC-cell versus standard of care autologous stem cell transplantation. And both group of patients, they were randomized, 180 some patients were randomized in both group of patients. Now, the important point here was patients in the standard of care, there was no bridging chemotherapy was allowed. The only thing they allowed was the corticosteroid, and approximately 36% of patients in the XC-cell group, they receive corticosteroids as a bridging chemotherapy. On the other hand, in the standard of care, patients use standard salvage chemotherapy, primarily RICE or RDHEP, RGDP, or RESHEP, which are the standard chemotherapy that we use. After patients achieve a CR or PR, based on the investigator discretion, they went forward receiving to autologous stem cell transplant, or if they haven't had a good response, then they could receive CAR T cell therapy off protocol, which was allowed. Patients who were in XC-cell, those patients did receive the standard lymphodepleting chemotherapy, which we use cyclophosphamide and fludarabine prior to CAR T cell therapy. Now, the important thing in this study was primary endpoint was event-free survival, and there were secondary endpoints, primarily overall response rates and overall survival.
And so what were the results?
Yes, so now the long-term results were pretty impressive. These are the long-term results at approximately 4 years of follow-up. The median progression-free survival was clearly superior in XC-cell group with a median PFS of 14.7 months versus 3.7 months in the standard of care autologous stem cell transplant group. Hazard ratio was 0.51, so which means XC-cell reduced the rate of recurrence or death by 49% compared to stem cell transplant group. 4-year PFS was also clearly superior, 42% for the XC-cell group versus 24% for the standard of care stem cell transplant group. Now, also overall response rates were superior, 83% with the XC-cell and versus 50% for the standard of care. And importantly, CR rates were also superior for the XC-cell group. Now, side effect profile, as you can see here, they were primarily treatment-driven. Patients, higher number of patients with stem cell transplant had febrile neutropenia compared to the XC-cell group. Now, CRS rate and CRS-related side effects, they were higher with the XC-cell group compared to stem cell transplantation because of the nature of treatment. And also ICANS or neurological events, they were also higher with the XC-cell group compared to standard of care. And majority of these neurological events or CRS were responded well with the supportive treatment as well as tocilizumab and or corticosteroids. Now, another thing I want to mention is this is also one of the first trials for CAR T, which has shown overall survival advantage. Essentially, XC-cell has reduced the rate of death by 27% over standard of care autologous stem cell transplantation. At 4-year, overall survival was 55% for the XC-cell versus 46% for the stem cell transplant group. So Those data look pretty good. Median overall survival wasn't reached for XCell group versus it was 31 month or so for the stem cell transplant group. So the data looks quite good. And based on this study, XCell was approved in the second line setting for relapsed large B-cell lymphoma.
And what can you tell us about the lysocyl study?
Now, transform study was another study which used lysocell as a CAR T cell therapy, and that also randomized similar group of patients, primarily primary refractory patients, DLBCLs, or early relapse DLBCL, and those who received prior chemotherapies. Patients were randomized were lysocell versus standard of care, a salvage chemo followed by autologous stem cell transplantation. 92 patients each were randomized to each group. There were some subtle differences compared to the Zuma-7 trial. Main differences was this trial did allow salvage chemotherapy, and approximately 63% of patients did receive salvage chemotherapy prior to lysocell. The other more important difference was crossover to lysocell was allowed. And the third important difference was event-free survival. If patients had stable disease at 9 weeks, then those were considered event versus 150 days for the Zuma-7. So those were the few differences. But in general, when the data were matured last year, as you can see in this slide, median event-free survival was not reached in lysocell group versus 2.4 months for the standard of care group. Moreover, progression-free survival was also superior in the lysocell group versus standard of care group. And overall survival hasn't been matured yet, but there was a trend that overall survival was superior with the lysocell group. Now, one important thing I want to mention in the previous slide in the transform study is the CR rates were superior, 74% with the lysocell versus 43% versus overall with the autologous stem cell transplant. You can see here the important things are event-free survival hazard ratio was 0.36 or 35, which was quite superior, and overall and progression-free survival was also superior. So based on that study, lysocell got approved in the second line settings for primary refractory or early relapse large B-cell lymphoma patients.
So in your own practice, we have two CAR T cells approved. How do you choose which one to give to your patient?
Well, I think both CAR T cells, their results, and if you look at it, look at the hazard ratio and overall event-free survival, they are somewhat comparable. The one important difference is side effect profile. If you look at the CRS rate and grade 3 CRS and ICANS rate, with the lysocell, they were less than 10%. On the other hand, with the XCell, those numbers were higher. So XCell does cause high rate of grade 3 CRS or ICANS, and that's why patients who are older, patients who have medical comorbidities, it is tough for them to tolerate XCell. Now, also in this trial, there was another trial, which was a pilot trial, which also showed utility of lysocell in patients not deemed eligible for stem cell transplant. Essentially, the main criteria that this trial utilized was patients who are older than 70 or patients who have poor pulmonary function tests, DLCO less than 60%, or patients with impaired cardiac function less than 50% or so, or other comorbidities. Those patients were included. And despite those are the patients that we usually are hesitant to offer stem cell transplant. And even with those high risk group of patients, as you can see here, overall response rates was 80% and CR rates were 54%. And median progression-free survival at 1 year follow-up was 9 months, and overall survival was not reached. So this trial also showed us that these even patients who are frail or those who have other comorbid conditions, they can safely tolerate lysocell as a CAR T cell therapy, as a curative modality. And that gives us the more reassurance that this CAR T cell therapy would be more beneficial for older patients. So in my practice, I think I follow their comorbidities, performance status, and also I definitely follow the evidence. And I think lysocell has a good evidence of safety as at the same time, good efficacy in high-risk group of patients.
So, before we end, what your crystal ball, what does it tell you? Where are we headed? What are some of the new innovations coming in the years in the second line space that you are excited about?
Well, I think the one of the important thing that we are headed is, I mean, yes, CAR T cells are approved, but now we are we are testing if the CAR T cell therapy can be utilized early on in patients with high-risk lymphomas. Like there was a Zuma 12 trial, which essentially looked at high-risk lymphomas like double-hit lymphomas or high-grade B-cell lymphomas, patients who have not achieved optimum response or less than CR during interim scans. Those patients were included. And despite including those high-risk group of patients, there were significantly higher number of CR rates were achieved with CAR T cell therapy. So I think in the next few years, we will learn more about it, whether CAR T cell therapy can be moved to the frontline settings. I shouldn't say frontline, but can be moved in the high-risk group of patients more sooner than waiting for them to fail 6 cycles of CHOP or RCSP plus polatuzumab. So those are the things that I'm more looking forward to. And of course, we always worry about side effects profile with the CAR T cell therapy. So there are some trials ongoing utilizing novel agents to minimize toxicities of CAR T cell therapy, which is also another important thing that I'm looking forward to.
Well, I really appreciate you taking the time today to talk to us about these important trials, and I hope I can get you back in the future to talk to us about some of the newer developments as they unfold.
Thank you so much, Dr. Vij, for inviting me, and it was wonderful talking with you today. Thank you so much.
Thank you.